Hello and welcome to this online training session on patient assessment and scene size-up, hosted by Paramedical Services. During this training session, we're going to discuss the importance of forming a general impression of the patient, different ways of assessing the patient, the differences in assessing adults, children, and infant patients, and then we're going to discuss the importance of a good scene size-up, identifying the mechanism of injury and the nature of the illness, conducting a thorough primary assessment, and then the secondary assessment, including looking for our DCAP BTLS, obtaining a history using our AMPL and our PQRST, obtaining vital signs, and continual assessment of our casualty. Our general approach to any case or any call consists of four major components. The first is the scene size-up. This is a quick assessment of an emergency scene, and the purpose of this is to determine what situation we might be dealing with, what mechanism of injury there may be to the patient, and do we need any other resources to effectively manage the scene. The next is to conduct a patient assessment. This consists of our DRS ABCD primary assessment, which enables us to identify and begin to correct any life-threatening injuries to the patient. Following that is the secondary assessment. This includes assessing the patient's medical history, what degree of pain they might be in, and conducting a head-to-toe check, looking for any other injuries to the body. Following that is our management and interventions, which will be determined by what we find in our primary and secondary assessments, and also by your skill level and your organizational policies. And the fourth component consists of your reassessment of your patient. This requires constantly monitoring the patient's condition, looking for any changes that may need your immediate attention, so watching for signs and symptoms of the patient either improving or deteriorating. When conducting a scene size-up, the first thing we need to assess for is for danger. We need to make sure that the scene is safe for yourself, bystanders, and the casualty. You may require the need of other resources such as police, traffic, the fire department, or hazmat. Ensure that the correct PPE for the situation is applied to yourself, your partner, and any other person who is assisting on the scene. When conducting the scene size-up, it's important to determine the nature of the illness or the mechanism of injury. This will give us clues to find out whether this is going to be a medical or a trauma case. This information can be gathered from the patient, family or bystanders, and just a visual inspection of the scene. If there is a significant mechanism of injury involved, we need to consider the need for spinal immobilization and if we need additional resources to do this safely. Do a quick visual check when you come onto scene of the total number of patients. You need to evaluate whether you are capable of handling this situation or if you require backup. If there is multiple patients on the scene, you need to begin triaging and sorting the patients from those who are critical and require attention immediately, from life-threatening injuries to the walking wounded that can have delayed treatment. When approaching the scene and assessing for safety, there are a number of different hazards you need to look out for. One of the first is environmental hazards. As pre-hospital care providers and paramedics, we work in all different types of weather conditions. We may be exposed to extreme heat, extreme cold, torrential rain, snow, extreme windy conditions, and lightning and thunderstorms. Other environmental hazards can be noise. Working in very loud or noisy environments can make communication a very difficult thing. So communicating with the patient or communicating with other members on a scene to try and ensure your scene safety can be very difficult. Noise often cannot be eliminated because of the environment you may be in. You may need to find alternative ways to communicate to keep yourself safe and possibly remove the patient from the noisy environment as quickly as possible and then commence your treatment. Because of the nature of pre-hospital care, we're not limited to working just during daytime. We often have to work night shifts as well. Working at night can bring a whole range of different environmental hazards too. The visibility, for one, is a big factor. It's very difficult to be aware of your surroundings and see much further than a few meters. And this can make it quite difficult to observe and eliminate other hazards that you may be confronted with on a scene. You may be sent into a scene where there could be hazardous or toxic substances from things such as industrial accidents or motor vehicle accidents involving trucks that are transporting hazardous substances. Ensure that you call for backup from the fire department and possibly the hazmat team to come and contain these toxic substances, and where possible, approach the scene from an upwind direction, keeping a really safe distance. Whenever approaching a scene where we are querying that there may be a toxic or hazardous substance there, where possible, try and approach from an upwind direction, as this keeps you more protected from any toxic substances. As you can be called into many different types of situations, you may be confronted with dangerous or violent persons, and also be aware that the patient that you're managing could also become aggressive or dangerous. So take appropriate precautions to ensure that you're safe while treating and transporting this patient. And there are a multitude of different rescue-related hazards, especially when dealing with motor vehicle accidents. There could be things such as broken glass, exposed metal, airbags deploying, other traffic on the road. And with any scene, you could be managing a very heavy patient, so you could be at risk of getting back injuries if you do not handle the person correctly. Being able to identify the significant mechanism of injury enables us to recognize early the need for spinal mobilization. This is very important as it determines how we conduct our primary and secondary assessments of our patients, and taking early precautions like C-spine stabilization, calling for appropriate resources to ensure that we can immobilize and manage this patient safely and effectively. Significant mechanisms of injury include ejection from a vehicle, death in the same passenger compartment, falls from over 3 meters, rollover of a vehicle, high-speed vehicle collisions, vehicle pedestrian collisions, motorcycle accidents, any trauma patient that has an altered mental status or who is unresponsive, and penetrations to the head, chest, or abdomen. Being able to recognize these significant mechanisms of injury help you to direct your treatment early on to support the C-spine and protect the spine in the event of a spinal injury. However, causes of a spinal injury are not limited to this list. There are many different other causes of a spinal injury, and if any stage during your treatment that you pick up signs or symptoms or querying a spinal injury, assume C-spine stabilization. When conducting the primary assessment on the patient, it should begin with 3 basic questions. What happened? Can you take a deep breath? And do you have any pain? Asking what happened helps us to determine, is this a medical or trauma case, if it's not obvious by looking at the scene and conducting a scene size-up. This also gives you a bit of a history of the incident and how the patient came to be in this condition. If you ask the patient, can you take a deep breath? This helps us to identify that they're able to follow a command or obey instruction, which gives us a good indication of their level of consciousness, as well as the fact that they have a patent airway and they're able to ventilate. Asking the patient, do you have any pain? This enables us to locate the site of the injury rapidly, or in the medical case, it helps us to recognize and narrow down what might be wrong with the patient. It's important that we follow the systematic approach of evaluating the patient in the primary survey. We can do this by making use of our DRS ABCD. We've already discussed assessing dangers when arriving on scene and conducting a scene size-up. Take a quick visual of the scene, and if needs be, stop any life-threatening bleeding. If the patient has sustained some significant mechanism of injury, ensure that C-spine immobilization has been taken up. Assess the patient's level of consciousness using the AVPU score and the GCS. Then assess the airway, breathing, and circulation. In the event of a resus situation, D would stand for defibrillation, but in any other assessment, D can also be interchanged with deformity. So looking over the body, checking for any deformity or injury. As we've already discussed dangers and looking for hazards on the scene, we're going to continue on with checking a patient's response. We check somebody's response by touching, talking, and if unresponsive, we use a painful stimuli. We want to know if the patient is either alert, and if not alert, are they responding to a verbal stimulus? If they're not responding to that, do they respond to a painful stimulus, or is the patient completely unresponsive? The AVPU score is a very well-known system of scoring the patient's level of consciousness as a quick check before doing the GCS. When entering on any scene and looking for a response from the patient, check to see if the patient's eyes are open and if they're following you. Introduce yourself and see if there's any verbal response from the patient. If their eyes are not open, you can get down next to the patient, give their shoulders a squeeze, and try and elicit a response. You can also consider the cow's technique, whereby you call out to the patient, ask them, "Can you hear me? Open your eyes. What's your name?" And then place your hands in theirs and ask them to squeeze your hands. If the patient is unresponsive to either the verbal or the touch stimuli, then you can move on to giving a painful stimulus. In adults and older children, it is acceptable to do a sternal rub as a painful stimulus, but no pinching or slapping or causing injury to the person. However, when assessing the neonate or the infant child, it's unacceptable to give a painful stimulus by means of a sternal rub. You can, however, do something like running your fingernail underneath the bottom of their foot to elicit a pain response from them. We want to make sure that we don't cause any harm or damage to their delicate tissues. As I mentioned, besides just trying to get a quick AVPU score from the patient, we need to then determine what their GCS is. The Glasgow Coma score, or Glasgow Coma scale, was developed in the 1970s by the University of Glasgow. The GCS score was primarily designed to assess patients with traumatic brain injuries and head injuries to determine what their cerebral functioning was. They would do GCS scores multiple times throughout the patient's care or stay in hospital to help identify the extent of the brain damage and the prognosis of the patient. Even though this was initially designed just for head-injured patients, it has now infiltrated every area of patient care and has formed an integrated part of our vital signs assessment. When conducting a GCS, we assess and score the patient according to their eye response, verbal response, or motor response. Starting with eye opening, if the patient's eyes open spontaneously, they get a score out of 4. If the patient's eyes only open to a verbal stimuli, they get a score of 3. And if the patient's eyes only open with a painful stimulus, they get a score of 2. And if there's no eye opening at all to any response, they get 1. The next category is the verbal response. The patient would score 5 if they were completely orientated to time and place. If the patient was confused, then they would score 4. If they were using inappropriate words, for example, if you asked the patient what the date is today and they started talking about a cake recipe, it's something that's completely unrelated to what you were asking about, they would score a 3. If the patient had incomprehensible sounds, so mumbling, moaning, and groaning, but not actually forming proper words or sentences, they would get a score of 2. And if there was no verbal response, they would obtain a score of 1. The next category is the motor response. The patient can score 6 if they obey commands. So if you ask the patient to touch your finger to your nose and they obey the command, then they obtain a 6. If the patient, however, is in a semi-conscious state and you go to elicit a pain response and the patient reaches up and grabs your hand, they're able to localize the pain, they would score 5. If the patient was to withdraw or try to pull away from the pain, then they would score 4. If, when eliciting a pain response, the patient has abnormal flexion, so the patient's arms curl up and they try to protect or pull into their body, they would score 3. If they did abnormal extension on a painful stimulus, so their body fully extends out, pushing out their arms and legs, that would be a score of 2. And if there was no response at all, they would score 1. So the lowest score anybody who is completely unresponsive can obtain would be 3 out of 15. And the highest score of somebody who is completely alert and orientated with open eyes and obeys commands could be 15 out of 15. The GCS score is taken very seriously, and it's very important that as we are the first contact with the patient after any traumatic or emergency incident, that we do an accurate and a thorough GCS score, as the initial GCS and subsequent GCSs after that can give the doctors a really good idea about what is actually happening with this patient and what their prognosis would be. This is something that you do need to commit to memory and have lots of practice calculating in different scenarios. When arriving first on scene, we're doing a scene size up and assessing whether we need the police, traffic, fire, or hazmat, or is this patient in such a critical condition that we need somebody of a higher medical qualification, or do we need more hands on scene to provide medical care to ensure that we are safely managing this patient and getting them to hospital nice and rapidly? A is for assessing the airway. We need to ensure the patient's airway is open and clear in order to be able to ventilate appropriately. If the patient can talk well, the airway is open and clear. Ask the patient to stick out their tongue. This allows you to view the oral cavity and look inside the mouth for any swelling, any discoloration, and any trauma to the oral cavity. Then to open the airway in the unconscious patient, we need to do a head tilt chin lift or a jaw thrust in order to ensure the airway is open. Remember here that in any unconscious patient who is lying on their back, the tongue relaxes and it falls to the back of the airway, occluding the airways and causing an upper airway obstruction. So we need to perform either a head tilt chin lift or a jaw thrust to move the tongue anteriorly off of the back of the airway and allow for an open passage down into the lungs. The picture on the right hand side over here depicts the head tilt chin lift, and the one on the left depicts the jaw thrust. You will be shown how to do these appropriately in your face-to-face training session and have ample time to practice these maneuvers. When opening the airway in a newborn or an infant, we use slightly different techniques and approach to performing the airway maneuvers. This is because in the infant and the newborn, there's quite significant differences in the anatomy and the physiology. Firstly, the size of the head in the infant or the newborn is a lot larger in comparison to the body than that of an older child or an adult. Usually when they're in the supine position, just a small jaw thrust can help to open the airway nicely. We don't ever want to do a full head tilt chin lift on the newborns or the infants, because this can also kink off their airways that are not fully developed or protected by the cartilage rings yet. Another method at opening the airway is, instead of tilting the head back or doing a jaw thrust, is actually putting an object such as a towel underneath the shoulders to elevate the shoulders slightly, and again opening up the airway passages over there, like you can see in the picture on the right hand side of the screen. When assessing the breathing in a patient, we want to check for the rate. Are they breathing fast or slow? The rhythm, is it a regular or an irregular respiratory pattern? And the depth. We want to know, do they have a good tidal volume or a very poor or low tidal volume during their respirations? Have a look at the patient's posture. This says a lot about their degree of difficulty in breathing. If the patient is laying on the ground, semi-reclined, or just in a sitting position, they might be having no difficulty in breathing. Or is the patient leaning forward, assuming the tripod position, and engaging accessory muscles in breathing, they may be having quite severe difficulty in breathing. And listen for any noisy breathing or audible breath sounds. If the patient is unconscious, look for movement of the upper abdomen or the lower chest. Listen for escape of air from the nose or mouth, and feel for movement on the chest or upper abdomen. When assessing circulation, we want to have a quick feel for the rate. Is it feeling fast or slow? What's the rhythm like? Is it regular or irregular? Is it strong pulses or very weak pulses? And we can check different pulse points too. In the unconscious patient, we would initially go straight for feeling a carotid pulse up in the neck. However, in the conscious patient, we would rather be using pulse points such as the radius or the brachial pulse. In the infants and neonates, the easiest place to feel for a pulse on them is in the upper arm over here at the brachial pulse. They usually have too much fat tissue around the wrists to be able to feel a good radial pulse, and their necks are generally quite short, and it's quite difficult to feel a carotid pulse on the infants or the newborns. So the brachial is the best point for you to actually assess their pulses. Gathering a good history and history taking is absolutely key to you conducting a proper assessment and managing your patient appropriately. You start taking a history right at the beginning when you ask the patient, when you walk in on scene, what happened. So you're trying to ascertain their chief complaint, because the patient may have many ailments and many complaints or medical conditions, but you really want to narrow it down as why are they calling you today. One of the very common mnemonics out there is ample or sample. And this mnemonic is there to help guide you through your questioning the patient and obtaining a good and thorough history. Sample is the same with ample, just with an S in front. An S would stand for the signs and symptoms. So what has the patient noticed that their signs and symptoms are about what they're feeling at the moment? So that's again relating to their chief complaint. In ample, A stands for allergies. We need to ask the patient, are they allergic to anything or any medication? Because this could be why the person is in the condition that we find them. Or it could be that we need to avoid certain medications and warn the hospital about any particular allergies they have. Ask the patient, what medications are you on? Have you taken those medications today? If so, did you take the right dose? Are they in date? There's many questions that you can go into around the medications, but the medications can also give you a very good indication of the person's health status and what medical ailments they have. Asking the patient about their past medical and surgical history is pretty important as well. It all adds into painting the picture about what could be wrong with them. Ask the patient when last they ate or had any oral intake, as this could again be leading questions as to why they're in the condition that we find them in. And then lastly is, what were the events leading up to the incident? So how did they come to be in the state that we find them? You may note that in textbooks and lectures that people state that do your primary assessment and then your ample history and then the secondary assessment and your vital signs, but really it's all quite integrated, and you assessing your patient's history as you're going through your entire assessment from the beginning to the end, and it's all integrated throughout your treatment. So there's no particular point where you have to ask your history questions, but getting them in early is going to be the most helpful thing for you, because it's really going to be leading you down the right roads to the right assessments and then leading you to the right management of the patient nice and quickly. The next thing we need to have a look at is the vital signs. The vital signs are a window into what is happening inside the patient, and we use our vital signs for many of our protocols and pharmacology as guidelines about when to give certain medications, when we can't give certain medications, and also what interventions would be indicated to do in that situation. Our vital signs include things such as the person's Glasgow Coma score or GCS, assessing the pulses, that means the rate, the rhythm and the strength, respiratory rate, blood pressure, capillary refill, the temperature or skin temperature, skin color, oxygen saturations, ECG readings, pain scores, and pupil reactions. The first set of vital signs that you ever obtain from a patient are called your baseline vital signs, and that's because you will use that first set of vital signs to compare every other set after that against. In the stable patient, you only need to monitor your vital signs every 15 minutes, whereas in the unstable patient, you need to monitor the vital signs every few minutes, looking for any changes that may indicate your treatment is either improving their condition or the patient is actually starting to deteriorate. Vital signs differ at different age groups, so it's quite important to get some rough ideas about what to be looking for in the neonate, the infant, the older child, and the adult in regards to their breathing rate, their pulse rate, and their approximate systolic blood pressures. It can be quite hard to remember all the different estimated breathing rates, pulse rates, and blood pressures for each age group, but there's a lot of tools out there that are available for people in formats of pocket cards and apps on phones that can give you something to refer to when dealing with an emergency with anybody in these age groups. Assessing the pain on the patient is very important because this will also help us to determine later on what type of pain relief we're going to be administering and at what doses. We use the mnemonic PQRST to assess pain. P stands for provoke, so what provoked or caused the pain to start. It can also stand for palliate, so what actually causes the pain to go away or soothes the pain. Q is the quality of the pain. You need to ask the patient, what does the pain feel like? And they should be responding with either it's a burning pain, stabbing pain, crushing, or a dull, achy pain. So to give some description to what the pain feels like. Ask if the pain radiates. Does it move anywhere? In patients with cardiac disorders, they might have a central chest pain that then radiates down the left arm. And this is just helping us to narrow in what we think the condition could be. S is the severity. What is the score out of 10? So if 0 is no pain at all and 10 is the worst pain somebody has ever felt, they need to give us a score of their pain on a scale of 1 to 10. And T is the time. So when did the pain actually start? When we have an initial pain score from a patient, every time we do an intervention on this patient, or even if we can't do interventions on this patient, we need to regularly keep track of the score of the pain. Is the pain getting worse or is it getting better with what I'm doing? For infants and younger children who find it very hard to communicate, or even in patients that may have a language barrier or unable to communicate because of mental or physical disorders, we can use what's called the Wong-Baker Faces Pain Rating Score. And just having a look at the pictures at the bottom of the screen, 0 or no pain, you can see the patient looks quite happy. But gradually, as the pain level increases, the facial expressions start to look more sad and dismal until somebody is obviously in quite severe discomfort. And these are the two methods that are recognized and used to assess a patient's pain. After completing your primary assessment, taking a history and doing your vital signs, the next thing to do is do a complete head-to-toe or secondary assessment. This includes assessing the head and the neck, the chest or the lungs, the abdomen, the pelvis, the lower and the upper extremities, and assessing the patient's back. During the secondary assessment, we're looking for any other injuries or telltale signs about what could be wrong with this patient. And as we're going through the head-to-toe assessment, we're looking for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, or swelling. This mnemonic is known as DCAP BTLS. There are many other different mnemonics out there. These are just to help you to get in a systematic approach to assessing a patient and what to be looking out for. Now, when conducting a secondary assessment, this is really aimed at looking for injuries in the trauma patient. However, we can do an adaptation of the secondary assessment in the medical case, just filtering out a few assessments. Starting with the patient's head, when we're assessing the head, we need to feel all the bones of the face and around the head nice and firmly, making sure that we are checking for any fractures, looking for tenderness, instability, or crepitations, otherwise known as the mnemonic tic. Look for battle signs or raccoon eyes. Battle signs is the bruising behind the ears, and raccoon eyes is the bruising around the eyes, which can indicate things such as a base of skull fracture, but those can sometimes only develop hours after the injury. Look inside the mouth. Note the color of the mucous membranes in the mouth, and look for things such as blood, vomit, broken teeth, trauma to the airway, or swelling of the tongue. And looking for any bleeding from the nose or the ears. This is called rhinorrhea and otorrhea. While assessing the head of the patient, it's important to check the reaction of the pupils. It can tell a lot about the patient's condition and can give you clues as to what might be wrong with them. When we're assessing the pupils and the reaction to light, we need to assess the size of the pupils, the shape of the pupils, the speed of the reaction, and the direction of the person's gaze. Unequal sized pupils, as shown in the picture on the right, can indicate either the person has a rare genetic abnormality in which their pupils are naturally different sizes, or this could also indicate something more severe like a head injury, nerve trauma, or a stroke or a CVA. If the patient's pupils are both dilated, this could indicate something such as a sympathetic stimulation from recreational drugs or medications, or it could also indicate something more severe like cardiac arrest or a reaction to medications. Somebody may have irregular shaped pupils, again due to nerve damage, particularly with the ocular nerves, and this can also be a genetic malformation of the pupil. The direction of the gaze, so if the patient has a fixed gaze to one side, both eyes are looking in the same direction, this is called a conjugate gaze. You can also get a disconjugate gaze where the eyes are looking in opposite directions, or there could also be nystagmus, which is an involuntary jerking movement of the eye, and this is all related to the nerves that control the movement of the eyes being damaged. Small or pinpoint pupils can indicate a stimulation of the parasympathetic nervous system, either from things like a funnel web spider bite, organophosphate poisoning, or the use of recreational drugs such as opioids or heroin. When assessing the patient's neck, maintain inline stabilization with any patient that we may be querying a spinal injury. Then assess the cervical vertebra for tenderness and deformity. Check the anterior neck for any tracheal deviation. Look for subcutaneous emphysema. If you have a look at the picture on the right hand side over here, you can see the left side of the patient's chest looks normal. You've got good definition of the collarbone there and the anterior chest. Whereas the right side of the patient's chest, it's quite obvious to see that air trapping underneath the skin. It almost looks quite swollen, and that's the subcutaneous emphysema. Sometimes you can't see it very well, but you can feel it really well. So if you actually palpate the anterior chest around the neck and the collarbones, you'll actually feel the air trapped underneath the person's skin. And checking for any distended neck veins as shown in the picture on the right hand side over here, which could indicate something like raised interthoracic pressures. Moving down from the neck to the rest of the chest, so we follow the same principles of look, listen, and feel. First, look for any decapped BTLS. Look at the rise and fall of the chest, if there's a good tidal volume or if they're breathing quite shallow, and make note of that. Check for symmetry of the chest, as asymmetry or unequal chest rise and fall could indicate something like a pneumothorax or a tension pneumothorax, so watch out for that. Then you need to have a listen to the air entry, and we do this by auscultation through our stethoscope. When auscultating the apexes and bases, we want to compare apex to apex, then base to base, to ensure that we've got equal air entry in both sides. So we would put the stethoscope on position 2, then position 3, and then position 6 and position 7. Please just make a note here this is about the area of the xiphoid process, and when auscultating the bases of the lungs, people often make a mistake of going right down at the base of the ribs, and then they're not auscultating lung sounds anymore. They're auscultating vibrations of lung sounds into the abdominal cavity. So you need to make sure that you are actually listening at the level or higher of the xiphoid process to listen to the base of the lungs. On obese patients, it may be easier to have a listen to the back of the chest, and also depending on the position we find the patient in, if we want to do a quick auscultation and hear the air entry before moving the patient, it's good to assess the back as well as the front. Then we need to feel and palpate the chest. We're feeling for any tenderness, instability, and crepitations. And we do that by springing the ribs on the sides and then pressing down gently on the sternum. And that way we're flexing the ribs from all sides and checking for stability and assessing whether or not there's any fractures or pain. Now at the bottom of the page over here we have a website available for you to have a look at to try and recognize and get comfortable with different breath sounds. If you'd like to pause the video now and write down that web address or copy it down, that would be great. And they have small clips of all different types of breath sounds, and it's really important to get your ear tuned into those different breath sounds and what they mean, so that when you do hear it on a patient, you can know exactly what it's related to and you're not stuck sitting there thinking, something sounds strange, but I don't know what it is. So please take the time to really have a good listen to all those different breath sounds that are on that web page and get comfortable and confident with recognizing them. Next is assessing the abdomen. So we look for, again, DCAP, BTLS. We inspect and palpate all the 4 quadrants of the abdomen. We do this gently by putting our hands on top of each other and slowly working our way from one side to the other, going over every inch of the abdomen, pressing in gently to check for anything like tenderness, rigidity, any abnormal masses when the patient is guarding, or if there's any abdominal distension. Moving down to the pelvis, we want to observe and look for any DCAP, BTLS. If the patient is not complaining of any pain, then you can have a feel of the pelvis, checking for tenderness, instability, and crepitation. We can do this by conducting a pelvic squeeze, where you push in on the iliac crests and push down on the iliac crests, and you can also push on the symphysis pubis, but make sure you do not rock the pelvis from side to side, as that can cause further damage and injury. Check for any incontinence, and also check for priapism, which could be an indication of a spinal injury in the male patient. When assessing the extremities, carry on moving down the body first and assess the lower extremities, and then move up to the upper extremities before checking the patient's back. Look for any medical identification devices such as a medical alert bracelet or a tattoo, and assess the extremities for DCAP, BTLS, feeling for any tenderness, instability, crepitus. Assess the pulses on the legs and the arms and the motor and sensory function. Have a look at the skin temperature and the color, and assess the capillary refill to check the circulation right down at the fingers and toes. And you can also check for skin turgor by pinching the skin on the hand, and if the skin stays raised, it's an indication that the patient is dehydrated or hypovolemic, and if the skin smooths back down quite easily, then it indicates that the patient is well hydrated. And don't forget to assess the patient's back. With the patient where we're querying a spinal injury, the time that we would assess the back is when we had the spine board ready to slip underneath the patient. So what we'd like to do is, once we've assessed the whole front of the body, supporting the neck, keeping inline stabilization, we would roll the patient onto their side safely, palpate down the spine and check for any DCAP, BTLS down the whole of the back of the body, and then slide the spine board in underneath the patient and roll them back onto the spine board. So we only have to roll them once before moving. When do we just do a focused secondary assessment? For any conscious trauma patient with no significant mechanism of injury, you can conduct a focused assessment around the area that the patient tells you is painful. For example, if you were on a medical standby at a school rugby game and a child went to catch a rugby ball and it bent his finger back and he came running to you in pain and his finger was dislocated, it wouldn't necessarily require us to do a full head-to-toe assessment on this patient. We could do a focused assessment just on the finger, on the area that was injured, because there wasn't a significant mechanism for injury indicating that there could be other injuries in the body. When conducting our focused secondary assessment, we again check our DCAP, BTLS, ask our PQRST questions, check for TIC, which is tenderness, instability, crepitations indicating a fracture, and check for the pulses, motor, and sensory responses. And for the medical patient, again, we can do focused assessment on the part of the body that they are complaining about. So if the patient comes to you and is having an asthma attack, complaining of shortness of breath, we would do a focused assessment of the chest, auscultating the lung fields, feeling for equal rise and fall of the chest, watching for tidal volume, and getting a respiratory rate. We wouldn't necessarily do a full head to toe on this person. But you can still observe for any DCAP, BTLS, ask the PQRST for medical as well, and ask the ample history. Once we have conducted our primary assessment, assessed the patient's medical history, got vital signs, and conducted a secondary assessment, we need to constantly monitor the patient's condition while providing any intervention or care. We need to repeat all vital signs every 15 minutes for a stable patient and every 5 minutes for an unstable patient to watch for any changes from that baseline set of vital signs to indicate improvement or deterioration. We also need to continuously reassess the mental status, so the GCS, reassess the patient's airway, making sure it's open and clear, monitor the breathing rate and the quality of the breathing, reassess circulation, and reestablish patient priorities depending on what you find. It's also good to repeat the focused assessment regarding the patient's complaint or injury, again to ensure that you're managing the situation appropriately and to pick up if anything has changed. When providing any care to a patient, we need to apply the mnemonic PI: plan, implement, and evaluate. Plan what you're going to do for the patient, implement your treatment, and evaluate if it's worked. This cycle will continue on and on until you provide your handover either to another medical professional or at hospital. When handing over a patient to another medical professional, it's important to understand that this is a legal transfer of your professional responsibility and accountability of that patient. A poor or an absent clinical handover can result in a delay of treatment for the patient. There could be missed or duplicated tests, and the patient could actually ultimately receive the wrong treatment and medication errors. In order to provide an accurate and relevant handover, you can make use of tools such as I missed AMBO. I would stand for identification of the patient, their name and personal details. M is the mechanism of injury or medical complaint. I is the injuries that they sustained. S, all the signs and symptoms and vital signs. T, the trends of those vital signs and the treatment that was provided. And then allergies, medications, background of the patient, and any other vital information for the handover. Other countries make use of ISBAR. I is identifying yourself and the patient. S is the situation, the diagnosis or the reason for admission. B is the background or patient history. A is the assessment, observations, and vital signs, as well as the treatments provided. And R is any further recommendations for this patient. In overview of the patient assessment, for the medical case, a scene size-up should be conducted, a primary assessment, a focused assessment based around the chief complaint, ample and PQRST assessments, baseline vital signs, and continued reassessments before handover. In the trauma case, scene size-up should be conducted, primary assessment with C-spine inline stabilization if there's the presence of a significant mechanism of injury, focused assessment based around the chief complaint, the ample and PQRST assessments, baseline vital signs, followed by a secondary assessment. Being able to conduct a good and thorough scene size-up and patient assessment is an essential skill of any medical professional. It is a skill that does require time and lots of practice to perfect, so ensure that during your face-to-face training and ride-alongs, you make ample time to practice these skills and become confident and comfortable in performing them. Thank you for joining us for this online lecture on scene size-up and patient assessment. If you have any questions regarding any of the information discussed today, please don't hesitate to contact us.